Hi. I have about 100 questions, but I'll just take one. What I'd like to know is, when you start after you go through this evaluation and you do the surgery, what time period, besides the 4 weeks before you program, what does your head all go through? You have holes drilled in your head, and speaking as a woman, we're a little vain. Does it look normal after a period of time? Do you have your hair grow back?
Okay, so I'll tell you my typical patient, and Alex can tell you his, but I don't shave any hair. Okay, I part your hair and I operate through the part. I'll shave the smallest little line through your part, but most patients, they don't know they've had surgery unless you're a completely bald male. You will definitely see an incision. And the care is 3 days after surgery, you can wash your hair with shampoo, any shampoo. And most people are returning to work, by that time and going back to their own business.
Yeah, my protocol is exactly the same. We do a little bit of shaving through a hair part. All of the surgery is behind the hairline, so none of it's visible after you heal. I think 3-4 days of, sometimes people feel just like they had surgery. I mean, that's what I would say. Sometimes they feel a little bit of brain fog for a week. But usually by about 2 weeks out, all my patients are, kind of back to what they've been doing.
Do you find that because you do the surgery with anesthesia, does that cause any potential cognitive decline?
That's a good question. I don't think that there's a significant difference between doing it awake or asleep. Usually putting in the battery is under general anesthesia, no matter how the leads are put in. So I don't think that's the contributing factor to some patients feeling a little bit off. I think it's just having brain surgery. The other thing is when we do brain surgery, sometimes some air gets into the skull and that goes away, but it sometimes takes a few days. So I think that's why some people feel, a little bit off, but everyone's a little bit different. But that's why a lot of this stuff like preoperative neuropsychology testing and so forth, it helps us with that.
Boy, go.
After you've had one, what does the battery replacement involve, and how frequent do you have to?
Sure.
How do they do that?
So the question is, after you've had the surgery, what is the replacement like? If you have a generator, it's going to have a life, right? It'll die out over time. Now, some of the generators last 3 to 5 years. Some generators, new generation, are going 8 years. And you have also the option of rechargeable generators where you charge it twice a week or something like that for an hour. And that way, those can last for 15 years, at least. So the actual process of replacing a generator it's a 15-minute operation. So you come in, same-day surgery, we open up the same incision we did, we take out the generator, put in a new one, close it back up, and send you out. And you're good for another 3 to 5 years. So it's a very non-invasive, same-day procedure.
Yeah, so that's exactly right. The replacement is typically under twilight sedation, so usually not even under general anesthesia. One thing, I know we've talked a little bit about rechargeable versus non-rechargeable. I would say in my practice, and Dr. Duma can chime in also, I would say probably 90% plus patients go for non-rechargeable batteries in my experience. There are more people electing to have rechargeable batteries, but definitely historically people have gone towards non-rechargeable. And the main reason I think is just you don't have as much upkeep on a weekly basis having to remember charging. The one downside of a rechargeable battery is if you forget to charge it and it runs out of juice, you may be walking around somewhere and your symptoms come back you know, and you're wondering why. And so most patients still go for non-rechargeable batteries. I don't know if that's, yeah.
Great.
The tremor, but the tremor for an individual is only on one side. Do you still implant 2 leads?
Yeah. So that's a great question. So it is possible to do just wires on one side, and in some select cases we do that. Typically in the setting of Parkinson's disease, if there's any sign at all that someone has symptoms on both sides, then we will often elect to do both sides. And the reason is this. So one thing that's great about DBS is you can often reduce your medications. And so what can sometimes happen is if you have symptoms on one side and then we treat it with DBS and the patient says, oh, well, I'm doing great now, I want to reduce my medications. They reduce their medications and now they start seeing symptoms on the other side that's not treated by the DBS. Or a year or 2 later, if Parkinson's progresses, then they have symptoms on the other side and then they go back and do another surgery. So while it is possible to put it on one side, and sometimes we do that, most patients end up having it on both sides. I don't know. You want to...
Yeah, I agree. I tell the neurologists and the patients, if you can draw a straight line down the middle and one side of their body is perfect and the other side is affected, sure, we'll do one side. But especially for Parkinson's disease, it's going to hit the other side. It's a bilateral disease usually, eventually. So it's kind of good to get it all taken care of at once. And by the way, there's a synergistic effect of having 2 working instead of just 1. So you know your effect might be better with 2 than it would be with the 1 alone.
If you are a DBS candidate, what is the percentage of people that the panel will reject, and what is the main cause for the rejection?
You mean physical rejecting the device?
No, the panel has decided.
Oh, the panel. Well, it's only up to Belinda. Belinda just says yes or no. So you better, you know, slip her $100 bill under the table, and it's a very democratic process. What percentage do you think are not candidates after we send them through the on-off testing? You realize that we do a videotape testing. This is for everybody. We do a videotape testing, but for the Parkinson's patients, they come in off their medication for at least 12 to 18 hours. So they come in rather rigid, stiff, and at their worst, and then we videotape them. And then they take their medicine after the first videotaping. We wait about an hour or 2 for their medicines to kick in, and then we test them again. And we can score them, and those scores are important for Medicare, for example, to approve the process. So there's a lot at foot here, especially your insurance. So if you don't pass that test, in quotes, it may not get paid for, or Medicare may not pay for it. So, but in general, we're pretty darn good at getting patients to their, I would say 90% chance you're going to get taken for surgery or get accepted.
If you are a candidate, then you get the DBS. The panel doesn't just reject people. The panel is there to double check and make sure that everything has been covered. And that way one doctor isn't just saying, oh, I'm just going to do DBS and do DBS and do DBS. That's what the panel is for, right? And so this is where we are double checking each other, making sure everything is fine. So again, if you pass all those tests, you will get the DBS.
Is there a common definition of ideal candidate? I would say that most people who are candidate for DBS are patients who respond to medications. So that's the first thing. So typically it's patients who, let's say, you take your medication, you have, let's say, 2-3 hours of on time at first, and then maybe an hour of off time, and that interval of how much on time you have gets shorter and shorter. That's one candidate who's perfect for DBS. The other are patients with just super disabling tremor. And those patients are great candidates for DBS as well. And then, ideally, we don't want, we would hope that you don't have severe dementia, those sorts of things that Dr. Teryzn talked about. But those are the two main things.
I agree.
This question's for Dr. Teryzn, if I've got that right. Where do hallucinations fall on the scale between impairment and dementia? And secondly, how should a care partner respond to their partner showing hallucinations?
Okay, yeah, so some, visual experiences like seeing shadows in the periphery and things like that, that can happen, but it tends to signal that there's a slightly more atypical course. So a person might still have mild cognitive impairment, and they might stay at that level, but there's a higher chance of progression when those symptoms are present. That also triggers us to be careful to identify if we're looking at a Lewy body disease versus a Parkinson's dementia. So those are things we would have to assess for. If a loved one is having visual hallucinations that are more complex, some individuals will see people, they'll have a sense of presence, they might see animals. I will say in my experience, some people are not bothered by the hallucinations, but others are. If it's paired with some delusions, like, maybe one I've heard many times is a belief that maybe a spouse is unfaithful, things like that. But I would say, similarly to how I advise people if a partner has significant memory impairments, if they're forgetting a lot, is to try to acknowledge and then redirect. It doesn't necessarily help to say, no, nothing's there, you're wrong, or you forgot again. It's much more helpful to sort of, I don't want to say lie to the person, but sort of gently acknowledge that they do see that and then redirect them to something else. Change the subject, essentially, because it does cause a lot of distress when the person that is already having these symptoms keeps being told there's nothing there, what are what's wrong with you? Or, so that's what I usually advise patients. Did that answer your question?
What's the standard now for how many surgeries you have? Because I've heard before that sometimes people have one lead put in 1 week, then next week another one, and the next one the battery, or is it quicker than that now?
Well, yeah, it's changed a little bit over the years. As Dr. Taghva mentioned, the gold standard at the time, way back when, was to have patients awake, first of all. When I first started doing DBS, I did everything all at once. So I did the generator, the head, and it was like a 7-hour day for the patient, and I did them awake. So they're awake during a 7-hour session. If you go to another hospital that is an academic hospital in Orange County, your DBS may take 9 hours, 8 hours for the whole day. And I think that's a lot to put a Parkinson's patient through, especially when they're off their medications. I mean, it's almost torture. You're in this frame, you're being held in that position for 8 hours, and you're awake for a lot of it. So there's the advantage of having an asleep surgery where you're asleep. But to answer your question, my typical patient undergoes 3 surgeries. I do the one side of the head first, and then I have them spend the night and they go home the next day. Then they come back a week later and we do the other side of the head. And then same thing, they spend the night and they go home. And then 5 days later, so that's a Wednesday, and then Monday, they come back and they get the generator placed. That's while they're asleep, and then they go home that day. So it's three surgeries, and there's a certain amount of rationale to that. Number one, if I'm doing them awake, I don't want them to be awake 7 hours. So my surgeries only take 2 hours. So you're with me for 2 hours, and of those 2 hours, you're awake about 15 minutes of the surgery. So you're in twilight sedation. I wake you up in the operating room in 15 minutes. You're awake, testing, holding a cup, that type of thing, looking for side effects. Then you go back to sleep with propofol. Everything's with propofol. And then you spend the night and you go home, and a week later. One of the rationales is that the shorter the operation, the less risk of infection. The other rationale is that you get less air into the head when you have only one burr hole than if you have two. It's kind of like the tomato can, you know, the can of soup. You put two holes in it and it pours better, right? More air can get in with two holes than with one hole. So there's that rationale. And when air gets in there, brain will shift. The brain will shift when air gets in there. So this is what led me to go that direction. And can I be convinced? Can you say, Doc, I want you to do it all in one sitting? Of course. I used to do it that way. So sure, we'll be glad to accommodate that, but I've been doing it this way for 10 years. Okay? Dr. Taghva.
Yeah, I mean, I think that there's pluses and minuses to doing it in multiple surgeries. And the biggest one that's kind of the most compelling is what Dr. Duma said. When you do both sides, you know, there is potential for brain shift from one side to the other. In my practice, I mean, I've gone back and forth. I typically do these and put both leads in one surgery. There's times where we'll even do the generator in one surgery, but it does lengthen the anesthesia time. So I'm usually one surgery or two surgeries. You know, for me, my patients are under general anesthesia to begin with, so I'm not as worried about the awake time. But again, there's pluses and minuses, and I think a lot of this has to do on a case-by-case basis. So I'll give you an example. So some patients I see are on blood thinners for some sort of disease, whether it's atrial fibrillation or they had a clot in the past, those sorts of things. So for those patients, it is a little bit of a risk to stay off their medications multiple times, to stay off the blood clotting medication. So for those patients, sometimes we'll do it all in one sitting. For some patients, on the other hand, let's say they're a little bit, you know, potentially more cognitively impaired, we might only want to do one side of the brain, see how they do, and then space that out and do the other side of the brain. So I think it's a case-by-case thing, but like, you know, Dr. Duma said, if we're typically accommodating, and usually we do stuff not because we want to torture you, but usually because we think it's the right thing for you. So that's, you know, so there is some judgment call, and I agree with Dr. Duma. If you go to an academic center, your surgeries may take a long time. Typically, you know, with either Dr. Duma or myself, you know, so if I do both wires, we start at 7:30. We're usually done 10:30, 11. If we do the generator, probably between 12 and 1 o'clock. I guess I'm done. I guess that's it. 3 o'clock, we're done.
3 o'clock. It's 3 o'clock exactly.
It's 3 o'clock on the dot. That's okay. Sorry.
You gotta put another quarter in the machine.
Yeah. All right. Next question.
My question is, who nominates the candidate for the surgery? Is it the patient comes to you or the regular neurologist?
So that's a good question, and just in a couple of these questions, I'm sensing a little bit of anxiety about, you know, being nominated for it's. So this is. We have a very sophisticated team of movement disorder neurologists between Dr. Schaefer, Bixby, and, you know, Thakar, and all of our movement disorder neurologists. Dr. Cerami, sorry. They do a great job screening and finding candidates. So when the patients are presented at our meeting, it's almost a confirmatory process, and to see is there something else the team has to add, or is there some really, you know, unforeseen red flag that would prevent this patient from having surgery. So really, who nominates is your neurologist. But again, you know, if you are a candidate for DBS, you will get DBS if you see one of our neurologists. So it's not an issue.
My question is, can you, of the few people that have had this done already, could you have maybe one or two stand up and tell us about their experience?
Yeah. To them, I don't want to put them on the spot, but if they're happy to. Sure, yeah, stand up, yeah, go ahead. Yeah, if you want to, yeah.
Give her a microphone.
I have 4 wires in my brain. 2 for essential tremor, and 2 for Parkinson's.
Okay, give her the microphone.
I have 4 wires in my brain, 2 for essential tremor, 2 for Parkinson's, and I have the generators in my chest. The surgery was done in 2004. If I did not have these wires on, my head would be shaking and I would be talking like this, and I would not be able to feed myself. So you can see what the generators have done for me. It has been a miracle in my life. Dr. Duma did a wonderful job, and I stand here before you. So I would be in a nursing home without these wires. When I go in for surgeries, other than brain surgery, the nurses look at me as if they're scared of me when they turn off the wires. So what a difference it has made in my life.
Thank you so much for Sergio, and I haven't forgotten about the other questions. If it's okay with the panel, if we can maybe go another 5 or 10 minutes. Sure. But I'm going to have Mark share his experience. Thanks, Mark.
I had the surgery on December 1st, so that's, 8 months or so. I've got, if you want to see a picture of what the stitches look like, Dr. Taghva does good work. Although I'm still getting balanced bills from the hospital, but that's a whole different subject. They performed the surgery in 2 different surgeries. One drilled the holes, and the other one to put in the stimulator. And so that went very well. It made sense to have that separation, I think, in between the surgeries. And before the surgery, I couldn't button a button or tie a shoe without the tremors impacting it. And so afterwards, I'm just fine. I mean, I noticed a substantial difference. So if anybody, in fact, I don't know if anybody had this phenomenon or not, I got 20 friends who email me every time I went to the doctors. What's going on? What's the status of this? So I started writing my own newsletter. And every month I publish a newsletter and send it to 20 friends who then now know exactly what's going on, so I don't have to answer 20 phone calls or 20 emails.
All right, I think of these two, that gentleman, and then over here. I'm trying to remember, which is the thing. I need to go and see Dr. Teryzn.
You're a physically active person. You have the electrodes placed on the right side of the chest, leading to your brain. Can you still do those activities such as playing tennis or swimming, etc.?
Short answer is yes. I usually tell patients, especially if they're doing overhead activities, swimming, tennis, those sorts of things, to wait probably about 4 to 6 weeks before resuming that. But we have extremely active patients, and DBS is really something that's supposed to improve the quality of your life and get you back to the things that you're used to doing. And so really, I don't generally impose new restrictions on any patient who's having DBS. We have athletes, triathletes, all sorts of people who had DBS who do very well with it.
I got a great story. I've got a patient from Mammoth, lives up in Mammoth area. She is about 70 years old, and she says, you have to put the generator on the other side. I said, why? She goes, it interferes with my shotgun. I said, are you kidding me? She says, nope, I'm a shooter. I go out, I shoot, I hunt, I do everything, and I'm not having a generator there. I said, done, left side. You can pretty much do it anywhere. I put one time in my career, put it down here low, because the patient had already had some sort of weird surgery here, had a cardiac pacemaker, and there was really no good place to put it. So I put it in the belly, I mean, or down in the lower abdomen skin.
Yeah, I wanted to interject this earlier in the day, but it's important to me. I'll be sitting around at a dinner table or a luncheon. Nobody can hear me. My voice is gone. And my wife tells me, why don't you take singing lessons? You got to sing in the car to get your vocal cords working. What is the deal on that?
Well, first of all, that's part of Parkinson's disease, right? Is hypophonia, a softer voice. Just like your writing gets smaller and smaller, your voice gets smaller and smaller. That's one of the problems with Parkinson's disease. But one of the first things that patients notice when they get DBS is that people understand me now, or they can hear me better. So the hypophonia is definitely improved with DBS. That's really one of the greater side effects of DBS, or not side effect, but treatment effects of DBS. So you should be, if you have that, I mean, I wouldn't get deep brain stimulation just because my voice was low, but you know, if you have other symptoms, it might be something to think about. Sure, speech therapy, others.
I agree with Dr. Duma. A great rule of thumb for DBS in general is things that get better when you're on with your medications are typically things that get better with DBS.
Is age ever disqualifying?
Sorry, can you repeat that?
Is age ever disqualifying?
Age. So not really. I mean, the main things that come with age, and everyone's different, would only be, you know, some of the things that Dr. Teryzn looks at, or whether medically you're unstable to undergo DBS. But just age specifically, just as a number, typically not. I don't know if you have a cutoff.
Well, for Parkinson's disease, it definitely affects your decision, because the older you are, there's more comorbidities. There are other things that, you know, you're not healthy with necessarily, that you may not be cleared for surgery. So, but the oldest essential tremor patient I've done is 91. Alex, I don't know about you, but probably
around the same age.
Yeah.
Yep.
So for essential tremor, I mean, they want to be able to eat, right? I mean, they can't bring a soup to their mouth. So at least help them in that regard, right? So that's fine. But yeah, for Parkinson's disease, I think the oldest patient I've ever done was in their mid to late 80s.
I have a question. I think I understand the benefits of DBS fully, but I'm concerned about the risk of brain surgery. So of the 900 surgeries that have been performed, what kind of complications did you have, and how many complications of those?
Sure. I think that's an important question. So the question is, you know, what are the risks? Typically, I always tell patients there's two serious risks and then other sort of minor risks. So the two most serious risks with DBS are, number one, the risk of causing bleeding in the brain when you do the surgery. And number two is the risk of causing infection. The risk of causing bleeding in the brain is less than 1%. Even in cases where bleeding does happen, the number of patients that it causes severe symptoms like stroke-like symptoms is still even less common than that. Because we know that's a risk, there are a lot of steps we take. So before surgery, we make sure patients are off all blood thinners. We check blood work to make sure your blood is clotting properly. After surgery, we very tightly control patients' blood pressure to prevent all those things. So that's risk number one. Risk number two is risk of infection. If you look at studies on DBS, that risk can range anywhere from 2% to 10 to 12%. The reason it's a serious risk is because oftentimes if patients have an infection, we have to take out the DBS. In our series at Hoag, the risk is under 2%. And part of it is when you come see Dr. Duma or myself, we're the ones doing the surgery. We don't have trainees, we don't have those things like you would get at, you know, other centers. So we're very careful. So our risk of infection is extremely low. but it exists. Besides that, the other risks are side effects during stimulation. And those now with the programming can really be reduced quite a bit. In some cases, and I would say this is probably 3 to 4% of patients, you have to go in and either put in an additional wire or move the wire that's in there to reduce the side effects. But you know, altogether, I would say that you know, we call this like brain surgery, and I think part of the problem with getting patients to do DBS, and I spoke with this to another group, is we call it this scary name. We call it deep brain stimulation, and I think this invokes ideas that either Dr. Duma or myself are like digging into your brain, and like, but really that's not how this is done. What this is done is basically with like computer navigation, we make a small hole the size of probably about a nickel, and we directly, through a very, very small needle, put the electrode in place. So even though the wire ends up in a deep place, the amount of damage or, you know, trauma to the brain is extremely small, and it's safer probably than any other surgery I do. But those are the main risks, and I don't know if Dr. Duma has anything to add.
Yeah, I echo what you said, Dr. Taghva, and I often look at the patient and say, you know, you're at risk without the surgery. Even at your best medical therapy, you're at risk just walking down a flight of stairs, or you're at risk, you know, falling and hitting your head and getting a concussion. So we're at risk in this population, and to the risk of that compared to the risks of surgery, one is at a very high risk that you're going to fall or have an injury, versus the risk of surgery is almost less than 1% of anything bad happening. And I think throughout your life, as a Parkinson's patient in particular, your risk of having an injury is way higher than 1%. So that's another way of looking at it. It's a educated, it's a calculated risk. The other, you know, there's really very few other risks of the surgery that Dr. Taghva mentioned. The brain, you know, we all look at brains. We see them in cartoons and things. He and I touch them, we feel them, we operate in them. The brain is basically Jell-O. It is the consistency of Jell-O, but it's Jell-O wrapped in saran wrap. Okay, so it's formed by this saran wrap coating. Once you get through the saran wrap, it's Jell-O, and all you're doing is putting a little swizzle stick through Jell-O. And the brain has absolutely no problem with it. It's actually extremely safe. Okay?
Just this gentleman's been waiting. One final question, and we do need to wrap it up for the day. I do apologize. Okay.
Okay, this may be technical. My wife